Mhm. Hi, Dr. John.
Can you hear me okay?
Yes, I can hear you now.
Okay.
I don't think we've met before, but I'm Sanchari. I'm one of the other chief residents. I'm working with Hiba and Cindy for next year. So,
Oh, excellent. I was wondering why is Hiba doing it? So you three of you are the co-chiefs, right? For next year? Oh, excellent. Okay. So, today hopefully it will be shorter. It's a tough thing to do. You try to cover everything so that the fellows, the residents will have everything to read and review, but at the same time, it becomes tiring, for people to talk and for people to listen. I don't know, how are others doing it? Are they covering it at length or are they only discussing the salient points?
so it really depends on every attending has a different style. Some just like to do questions and cover salient points that way.
Okay.
And then some are like you, we had a HEMONC attending also just do a PowerPoint covering like very important points. So yeah, we have a mix of both. I think we as residents would also prefer like a mix of both in each individual like board review session as well. So like some slides and then a question and then some slides and then a question.
Okay. Okay.
Yeah.
Then the only thing then is that it is going to get longer, or we should cut the content, So I'm trying to prepare slides so that you won't have to read anything,
I know, and your slides were excellent yesterday. Like I was on the session as well, and they were so good.
Okay,
Very
so we'll
helpful.
see. Maybe next year we can make some modifications. We'll see how it can be accomplished here.
Yeah, that's definitely. But like the residents definitely ask for the slides, so I hope they use it like before they actually go take the exam for a quick review.
Okay.
They're very good. So
okay, but today will be quicker because it's only 100 slides as opposed to 168 slides from yesterday, so it should be quicker. Okay. Great. So I'll just share screen and keep it shared. Is that good?
Can you see me at all? I'm not sure.
Yeah, I can see you.
Okay.
Yeah, but I might not recognize you when I see you on the floors or the house. So say hi to me if I don't recognize you.
I will. We also have our mask on the whole time.
That's right. That's right. Okay, great. Okay, let me try to share the screen. Do you see my screen?
Yeah.
Okay, perfect. So let me know when I should start and then I will go from there. Okay.
That's good. Maybe we'll give everyone till 6:05.
Great. That sounds good.
Okay.
Okay, thanks. So I have a question. Are you able to see the full screen or are you seeing my desktop also now?
I'm seeing your desktop also.
Okay, so I should make it full screen for you to only see the slides, right?
Yep, like the way you did it yesterday was great.
Okay, great, thanks.
Okay, Dr. John, I think we can get started now.
So we are going to take off from where we left yesterday. We are going to cover pancreas, gallbladder, bile ducts, and liver today. So it should be shorter compared to yesterday, and we will cover only the pertinent points. The other slides will be kept there for you to read and review. So going to pancreas, let me see, why is it not moving? Okay, acute pancreatitis. You see patients with acute pancreatitis admitted to the floor. So the most important thing to remember is that 80% of the patients with acute pancreatitis, the etiology is due to gallstones. So whenever you admit a patient with acute pancreatitis, if you don't know, I mean, most of the times you won't know what the etiology is, obtain an abdominal ultrasound. So if there is one exam that you should get for patients with acute pancreatitis is abdominal ultrasound. Getting a CT scan on admission for patients with acute pancreatitis is often, or 99% of the time, unhelpful, because a CT scan is needed if a patient is not improving 48 to 72 hours after the hospitalization. But on presentation, you get an ultrasound to look for gallstones. So if you find gallstones, then you can presume that the etiology is most likely due to gallstones. In an elderly patients above age 40, you might find malignancy as the cause. So when you have patients above age 40, after the pancreatitis episode is resolved, as outpatient, we might get a CT scan. We will get a CT scan to make sure there is no structural pancreatic lesion. But when you admit a patient, when the patient is hospitalized, the first scan that you should do is an ultrasound to look for gallstones. So there are certain medications that can cause pancreatitis, which include furosemide, estrogens, azathioprine, anti-HIV drugs. But these are all, I mean, a diagnosis of drug-induced pancreatitis should only be made after you rule out the common causes, which is gallstone-related pancreatitis. Getting triglycerides, if you don't find ultrasound evidence of gallstones, and also looking for hypercalcemia. And if in pediatric patients, the most common cause of acute pancreatitis is actually trauma. They have blunt trauma to the abdomen from injury sustained at a sporting event. So trauma is also a cause of pancreatitis that shouldn't be ignored. How do you make a diagnosis of pancreatitis? So if patients come in with a characteristic pain, which is severe epigastric pain, often radiating to the back, and if they have an elevation of the serum lipase or amylase greater than 3 times the upper limit of normal, then you don't need a CT or MRI. But if you have a patient with elevated lipase or amylase, and if they don't have abdominal pain, then you need to get a CT or MRI. Or on the other hand, if you have a patient who has a CT done for some other reason, and if you find that there is evidence of pancreatic inflammation or stranding around the pancreas, then if they don't have the abdominal pain, then you should get the lipase or the amylase to confirm or to make a diagnosis of acute pancreatitis. So to make a diagnosis of acute pancreatitis, you might need to do a CT or MRI if they don't have a lipase elevation or abdominal pain. But once you have a patient with acute pancreatitis, diagnosis based on clinical history and lab tests, you don't need to order an additional CT. What you should order is an ultrasound. I hope that is clear.
So sorry, I just have a quick question. So most of the times, these patients from the ED, they already have like CT scans. So at that point, would you recommend ordering another ultrasound to look?
That's a good question. Yeah, so what happens with CT scans is, when you talk about gallstones are cholesterol stones. Unless these stones are calcified, you will not see it on CT scan. Yes, if there is bile duct dilatation on CT scan, and if there are calcified stones, sometimes you might see it on CT, but CT is not a good test to look for gallstones. So you would still need a test or to look for gallstones if the CT is not showing a stone, or if the CT is not showing a pancreatic process like pancreatic lesion, pancreatic ductal lesion. Is that clear?
Yeah.
Okay,
Yeah. Thank
great.
you.
Feel free to interrupt me anytime, because it is actually the presentation makes more sense when you ask questions. That way it is, I mean, you will remember some of these questions that are asked much more than with a discussion that I give based on what I think is important. So I was going to, let me see the next slide. Okay, so when you have a patient with acute pancreatitis, so you make the diagnosis, you find out that it is due to gallstones, then you try to classify the patient as having mild, moderate, or severe pancreatitis. And so the mild pancreatitis patients have a diagnosis of pancreatitis, but there is no organ failure. So think of organ failure as a way you differentiate between mild and severe. So in moderate pancreatitis, there is organ failure, but it is transient. It resolves within 48 hours, and the organ failure does not persist beyond 48 hours. In severe pancreatitis, you are looking at persistent organ failure beyond, beyond 48 hours and involving one or more organs. So mild versus severe based on organ failure and based on duration of the organ failure. And what are the two main types of pancreatitis? There is an interstitial type and there is a necrotizing type. Interstitial type is where, I'll show you a picture later, it's just inflammation or stranding around the pancreas. In necrotizing pancreatitis, you're not able to make out the feathery pancreas. You can't make out the structure of the pancreas on imaging because there is necrosis that has already happened. And necrotizing pancreatitis, by definition, will be moderately severe or severe, because when you have necrotizing pancreatitis, you are bound to have some organ failure that goes with it. So here is a CT picture of interstitial pancreatitis. You can see that the outline of the pancreas is still preserved. You can see some stranding around the pancreas. But in necrotizing pancreatitis, you really are not seeing that feathery pattern of pancreatitis. You know that, yes, there is pancreatic tissue, should have been there, but the stranding that you see is also not homogeneous. It is, there is thick stuff there. So that is what we call as necrotizing pancreatitis. And most of the pancreatitis patients that you see are interstitial pancreatitis, which is mild, but most of the ones that are hospitalized are the ones who have necrotizing pancreatitis. So lipase is more sensitive than amylase. It rises early and it disappears late. So, so in that sense, if you can order only one test, amylase versus lipase, just get lipase because it rises early and it disappears late. What are the indicators of poor prognosis? So when you admit a patient with pancreatitis, look for the hematocrit greater than 44%. In GI, a low hematocrit, a high hematocrit is good because that means the patient is not having a GI bleed. But in pancreatitis, high hematocrit means hemoconcentration. That is, such patients are shown to have poor prognosis with, that's because of extreme hemoconcentration. The same way, elevated BUN, signs of renal failure, and also evidence of pleural effusion, pulmonary infiltrates, and extra pancreatic collections with altered mental status. All those things are poor prognostic indicators. Routine CT scan, okay, I've mentioned it here, not recommended at initial presentation unless diagnosis is clear. And CT with contrast in severe pancreatitis or in signs of sepsis, or if there is clinical deterioration of 72 hours after initial presentation, to look for pancreatic necrosis. So if you admit a patient with pancreatitis and if the patient is getting septic, or the patient is not improving after 48 to 72 hours, then you do a CT to look for necrosis. You will not appreciate if the pain started now, and if you go to the ED 4 hours later, and if you do a scan 6 hours later, you will not see necrosis that early. But if the pain started 2 days ago and for whatever reason you didn't get to the ED, then if you do a CT, you will see necrotizing pancreatitis. But if the pain started, you will have to wait for some time for the changes of pancreatic necrosis to appear on CT. So invariably, if you get a CT scan on admission, you will have to repeat a CT scan after 3 days if the patient is not improving. So then might as well wait for 3 days to do the CT, so the patient is irradiated only once. And then aggressive IV fluid replacement is what is recommended. This is something that has gone a full circle. Up until recently, we used to say that flood the patient with as much fluid as possible. But there is a beautifully done NEJM study published earlier this year showing that over-aggressive fluid replacement can lead to poor outcomes. So look at the patient, don't flood the patient with fluid if the patient is going into severe fluid overload, but make sure to give the patient enough fluids that the patient can. So hydrate the patient aggressively, but not at the cost of putting the patient to heart failure or significant pulmonary edema. And monitor BUN and monitor hematocrit with fluid replacement. If you see improvement of hematocrit, if you see improvement of BUN, these are all good signs. And early adequate fluid replacement is associated with decreased morbidity and mortality. And other thing is feeding. When you have a patient with pancreatitis, the traditional teaching in the past was give the patient bowel rest, don't feed the patient if possible. But if the patient is hungry and wanting to eat with no nausea, vomiting, try for early feeding. If the patient cannot tolerate PO or oral intake, consider putting in a NG tube or NJ tube. And if that fails, and if the patient is NPO for more than 3 to 5 days, you consider TPN. Don't consider TPN right away, because enteral feeding is important to prevent bacterial translocation from the gut. So try oral feeding. It's okay to keep the patient NPO for 2 to 3 days. Nothing will happen if the patient is not ready, but try oral feeding. If oral feeding is not tolerated because of nausea, vomiting, and delayed gastric emptying, consider NG or NJ tube feed placement depending on patient symptoms. If that fails, consider TPN, but don't ever choose TPN as a feeding of choice for boards and in real practice. And antibiotics are not recommended, even if it is necrotizing pancreatitis, unless and until you see evidence of infected septic pancreatitis, which I will discuss in a bit. So mild pancreatitis, start IV fluids if there is no organ failure. Severe pancreatitis, consider enteral nutrition within 3 days. And then if you can't achieve adequate nutrition in the 72 hours, you may start supplemental TPN, but try to put some food through the NG tube or the NJ tube if possible, to maintain the integrity of the gut mucosa and prevent bacterial translocation. What is this bacterial translocation? Think of your gut as having millions and billions of bacteria. And if the gut is not seeing food, there is increased permeability of the gut lining, the mucosal lining, and the deeper layers through which bacteria will track through the gut lining into the mesenteric lymph nodes, and from there get into circulation. But if there is food going, and if there is secretion of other fluids, the oral, the salivary glands, and the gastric acid secretions, the pancreatic biliary secretions, all those secretions, and if all those things are happening along with food intake, that intestinal gut permeability is decreased and prevents the chance of infection. If you are suspecting infected necrosis, so when do you suspect infected necrosis? If you have a patient with necrotizing pancreatitis, so the patient needs to have necrotizing pancreatitis, it should not be interstitial pancreatitis. The patient is just not doing well, is having the increasing white count and has fever, then you can consider empiric antibiotics, but ideally, a CT guided or EOS guided aspiration of the collection may be attempted in such patients before considering antibiotics. But that's the time to contact, get in touch with GI to see whether an aspiration is required. When do you do ERCP for pancreatitis? Remember, ERCP is a procedure that causes pancreatitis. One of the most common complications of ERCP is pancreatitis. So you don't want to do ERCP in patients with gallstone pancreatitis to relieve the stone. Sometimes it might be a small particle, a small piece of stone that would have caused obstruction in the pancreatic duct and triggered the process, and the stone might have gone, but the pancreatitis must have already set in and the manifestations might be ongoing. So doing an ERCP for gallstone pancreatitis is not indicated unless the patient has acute cholangitis. So choose ERCP only if the patient has acute cholangitis. Acute cholangitis patient will have fever, high white count, and elevated bilirubin, and features of bile duct dilatation and other findings on imaging studies. And one important thing is when patients present with gallstone pancreatitis, before they are discharged, they should have a cholecystectomy. That is a board question, and that is what we should aim for in real life. But surgeons might sometimes discharge the patient and plan the patient for interval cholecystectomy. It is not recommended, but we can only push for it. It's up to the surgeon to decide to do the cholecystectomy as inpatient or not. Pancreatic tumor should be considered in patients above age 40. This is something that you should always remember. I have been burned as a young attending, taking care of patients right after my fellowship. There was a patient that I saw. She was in her early 50s. She had pancreatitis. I found some gallstones. I thought it was gallstone pancreatitis. Luckily, as outpatient, she got a CT scan, and it was actually due to a pancreatic cancer. So when you have patients above age 40, and if it's gallstone pancreatitis, you will see some elevations of bile duct dilatation or abnormal LFTs. If you don't see any of that, in a patient with above age 40, and if they don't fit the picture of gallstone pancreatitis, make sure to get an imaging study after resolution of pancreatitis as outpatient. So not as inpatient, because you need to have all those pancreatitis changes to resolve to look for the pancreatic mass and to accurately identify the pancreatic mass. So patients above age 40, if you don't find a cause, get a pancreatic protocol CT. It is okay to have an unexplained pancreatitis in patients less than 40 years. So sometimes you could have patients who come into the hospital with pancreatitis. You do ultrasound, you don't see a stone. You look for medications. None of the medications are there. Patient is not drinking alcohol. You don't find a cause. You might call it as idiopathic pancreatitis and send the patient home. That's okay, as long as it's a younger patient. But whenever patients are age 40 and above, think of pancreatic cancer as a possibility. And I would say, even if I have a young patient these days with all kinds of cancers being seen early in real life, if I have a patient with unexplained pancreatitis as outpatient, I'm going to get an MRI pancreatic mass protocol with MRCP to make sure there is no ductal lesion or there is no pancreatic tumor. So keep that in mind. Acute pancreatitis, I mentioned serial BUN, maybe the most reliable sign, or serial hematocrit. Even hematocrit and BUN, if you follow that, and if that is improving, that's a sign of improvement of the pancreatitis. Don't look at amylase and lipase levels to predict improvement of pancreatitis. If you want to look at something, look at BUN and hematocrit. And ERCP should be avoided unless there is evidence of cholangitis. And asymptomatic pancreatic pseudocyst. This is a consult that we often get from the floor. If the patient has a collection which is not causing any symptoms, don't do anything, because they may resolve spontaneously in 4 weeks. And you might be actually, when you do an endoscopy, think of what you're doing. You're passing a scope through the mouth, through the intestine, and poking a hole into the pancreas and contaminating that fluid with all the contents, all the bacteria in the mouth and the intestinal tract, making that fluid collection infected. So you don't want to introduce infection into a fluid that is not infected. So always wait for some time for the pseudocyst to resolve spontaneously before you consider an intervention. Cullen sign and Turner sign, these are all due to hemoperitoneum manifesting as skin changes. Pancreatic pseudocyst, is a fluid collection.
I just had a question. So you specified that interstitial pancreatitis and necrotizing pancreatitis are managed the same way, mostly with IV fluids and enteral nutrition. So is one, does one have worse prognosis than the other, or?
Yes, necrotizing pancreatitis patients tend to have more complications. They will, if you have necrotizing pancreatitis, you are bound, the pancreatitis is most likely going to be either moderate or severe because there will be some organ failure associated with that. Interstitial pancreatitis patients are the ones who get admitted and are fine and get discharged the next day or the day after with no organ failure. So necrotizing pancreatitis patients will have moderate to severe, course, can have, a protracted hospital stay.
Okay, and of course, increased risk of superimposed infection.
Absolutely. And necrotizing pancreatitis, you make the diagnosis with the scan that is done 48 to 72 hours after admitting the patient when the patient is not improving with a CT scan, looking for those necrotic changes on the imaging study.
Okay.
Okay, great. So pancreatic pseudocyst, it's a collection of the fluid that leaks out of the pancreas. It's a pseudocyst. In the past, when I was in medical school, there used to be a 6 week, 6 centimeter dimension or duration that was considered to be an indication for drainage. So basically you would say, oh, there is a fluid collection around the pancreas that has persisted beyond 6 weeks. And if it is more than 6 centimeter in diameter, it has to be drained. That is no longer an indication. You intervene if there is symptom. If the patient, if the pseudocyst is causing compression of the stomach or of the duodenum, not allowing the patient to pass food from the stomach to the intestines, or if there is significant pain, or if the fluid collection is getting infected, that's when you drain it. Otherwise, you don't need to drain a pancreatic pseudocyst that you see in association with pancreatitis. So what are the fluid collections that you typically see in pancreatitis? When you have patients admitted to the hospital, invariably patients with pancreatitis will have some fluid collections, and the fluid collections that are homogeneous, you just see, some collection around the pancreas, and that fluid has no internal debris in it. It is very clear and it has no internal debris. That is what we call as the interstitial subtype or the acute fluid collection associated with pancreatitis. You don't have to do anything. They will resolve most of the times on their own. On the other hand, if you see fluid collection around the pancreas, which is not a clear homogeneous fluid, but with some internal debris in it, then you call it as an acute necrotic fluid collection. Again, this is also less than 4 weeks. For the definition of acute fluid collection, it has to be less than 4 weeks of duration. And again, you don't do anything with acute necrotic fluid collection. You don't want to introduce infection into that. And so when you call pseudocyst, pseudocyst is when the fluid collection, that homogeneous fluid with no internal debris in it, tends to stay beyond 4 weeks. So when it stays beyond 4 weeks, it usually has a well-defined capsule around it. You will see that there's a rind around it and the fluid is more organized. That is what we call as a pseudocyst. Cyst meaning, a simple fluid collection. But if that necrotic fluid collection that was present when there is internal debris, if that gets thickened lining around it, then you call that as walled-off necrosis. Walled-off necrosis is again encapsulated, has a lining around it, but the duration is beyond 4 weeks, and it is not clear homogeneous fluid. It is thick fluid in there. So this acute necrotic fluid collections that happens within 4 weeks, and the walled-off necrosis can become infected, and you suspect that when the patient does not improve or develop signs of sepsis. These patients should be started on antibiotics. So that's the time to start patients on antibiotics. If you have a necrotic fluid collection and if the patient is developing signs of sepsis, you should consider starting the patient on antibiotics. Otherwise, patients with acute pancreatitis do not need to be on antibiotics. And you may have to consider CT guided drainage or EUS guided drainage to debride the fluid collection But you always want to, avoid aspirating the content at least until 4 weeks has elapsed. Because what happens is when there is acute pancreatitis, there is some collection around the pancreas. It's not well defined. You put in a needle, you are not able to aspirate anything. You might get some fluid, but you are not doing the patient much service. But when it is beyond 4 weeks, there is a nice capsule around it. So you are not, you are able to aspirate the contents more, or you can actually place a stent there to continue to drain, because you may not be able to drain everything at one go. You may have to leave a stent there to continue to drain it. So avoid interventions of pancreatic fluid if possible within 4 weeks of the episode of pancreatitis. Chronic pancreatitis. So we mentioned acute mainly due to gallstones, but gallstones typically should not cause chronic pancreatitis unless you have multiple episodes of gallstone pancreatitis. But the most common cause of chronic pancreatitis is alcohol, so 60 to 70%. Initially, patients may have asymptomatic chronic pancreatitis patients may not have the characteristic pain, but eventually they will develop recurrent bouts of abdominal pain, and they will develop features of fat intolerance, steatorrhea, and diabetes. For diabetes to develop, 80 to 90% of the endocrine function has to be lost. And these patients, the chronic pancreatitis patients, you might sometimes miss the diagnosis of pancreatic cancer in them, because you tend to, when a patient presents to the hospital multiple times, you already know the patient by name, or you would have read the history and you make the diagnosis of recurrent pancreatitis, but you might miss that patient has a pancreatic cancer. And chronic pancreatitis, the chronic inflammation is a risk factor for pancreatic cancer. So you may have to consider imaging studies periodically on such patients when they present with persistent abdominal pain. What are the risk factors for chronic pancreatitis? I mentioned the most common risk factor is alcohol. Smoking is equally important. So if you have a patient with pancreatitis, chronic pancreatitis, you should counsel them on smoking. Alcohol, yes, alcohol has already done the damage. Continued pancreas, if the pancreas is already shot, there is no more damage that you're making with alcohol. It's not like the liver, where the liver has a capacity to regenerate, so you want to avoid alcohol. But with smoking, continued smoking increases the risk of pancreatic cancer. And there are some cystic fibrosis, hereditary pancreatitis gene mutations that you may want to know, but I'm not discussing that. That's not a high yield question for boards. One thing that is a high yield for boards is autoimmune pancreatitis, and I think a discussion of that is coming up soon. If it doesn't come up, I will talk to you about that. So how do you make a diagnosis of chronic pancreatitis? If you see calcification on a plain X-ray or EUS or MRCP or CT scan, when you do a CT scan or a plain X-ray, if you see calcification along the pancreas, that is very highly suggestive of chronic pancreatitis. And when there is significant pancreatic dysfunction, you will have diabetes and steatorrhea. As I mentioned yesterday, 72-hour quantitative stool fat is the gold standard just for steatorrhea, but fecal elastase less than 200, or staining, doing qualitative stain for fecal fat can also give you a hint. It's difficult to diagnose because you will never see. It's very rare to see pancreatic calcification on X-rays, and you invariably never get the 72-hour collection. And pancreatic, the qualitative stool testing for fat might be positive even in patients who do not have pancreatitis, chronic pancreatitis. So it is difficult diagnosis to make, but there are some endoscopic ultrasound guided criteria also that GI practice, GI service employs to make a diagnosis of chronic pancreatitis. Amylase and lipase are not helpful. Fecal elastase can be helpful. And secretin stimulation test, you don't need to know about that. That is another way that it can be diagnosed. So imaging findings in chronic pancreatitis, I said abdominal X-ray is very specific in the sense that if you see calcification on the pancreas, then you don't need to do a CT or MRI, then the diagnosis of chronic pancreatitis is made. CT of the abdomen, you could see pancreatic calcification, dilated pancreatic duct or pancreatic atrophy. MRI or MRCP also might show similar findings. a double duct sign when there is dilatation of the pancreatic duct and also the bile duct is very highly suspicious for pancreatic malignancy. So if you see that a patient with chronic pancreatitis has not just dilated pancreatic duct, but also bile duct, that means that head of the pancreas mass is causing obstruction to not just the pancreatic duct, but also to the bile duct, and that is pancreatic malignancy until proven otherwise. So what are the complications of chronic pancreatitis? You can have isolated gastric varices. So if you ever get a question on boards where a patient presents with bleeding and you do a endoscopy, you don't find any esophageal varices, but you see varices in the stomach. Think of isolated gastric varices happening because of splenic vein thrombosis. Because if you, I mean, I don't have that picture, but if there is thrombosis of the splenic vein, the collaterals that open up are actually veins that drain through the right gastric or the left gastric veins, which may open up as, which may manifest as varices on stomach. So if you have a patient with pancreatitis who is having a GI bleed, think about splenic vein thrombosis, and this patient's actually the treatment is splenectomy to get rid of the the thrombosplene, the thrombosplenic vein and the spleen. And so that is something to remember, the isolated gastric varices as a result of splenic vein thrombosis in patients with pancreatitis. How do you manage chronic pancreatitis? Stop alcohol, stop tobacco, small low-fat meals, pain control, NSAIDs and Tylenol, and non-entry-coated pancreatic enzymes can be given for pain, although it's not that effective. Malabsorption, if they have diarrhea, you would want to give them entry-coated pancreatic enzymes. Endoscopic therapy, if there are pancreatic duct stones, to remove those stones, you can try it, but usually not that successful. Celiac plexus blockade can give transient relief of pain, and sometimes you have to go and resect out the pancreas that is dead, which is pusto-lateral pancreatic jejunostomy. These are all surgical approaches to manage pain due to chronic pancreatitis. Autoimmune pancreatitis. This will be a question for boards. So in autoimmune pancreatitis, the buzzword that you need to remember is sausage-shaped pancreas. So patients might present with a pancreatic head mass. They might call it as there is diffuse enlargement of the pancreas and there's a pancreatic head mass. And there are instances where these patients are taken to the OR thinking that it is pancreatic head malignancy, and they take out the pancreatic head and do a Whipple surgery only to realize that it is actually autoimmune pancreatitis. So if you see, so when we have patients with unexplained pancreatitis, we typically send serum immunoglobulin G subclass, IgG4. Elevation of IgG4 is associated with type 1 autoimmune pancreatitis. And there is another type 2, where the IgG4 levels can be normal. This diagnosis is important to make. The characteristic picture on CT will be a sausage-shaped pancreas. The diagnosis is important to make because these patients respond beautifully to steroids. So if you start the patient on prednisone 40 milligrams with a slow taper, you will see that in about 4 to 8 weeks, the pancreas swelling and the inflammation comes down, and that the patient feels better. And those patients might need long-term steroids and steroid tapering sparing agents, but autoimmune pancreatitis, IgG4 elevation, sausage-shaped pancreas, response to prednisone. These are the important things that you need to know for boards. Pancreatic adenocarcinoma, I mentioned when you have a patient with unexplained pancreatitis above age 40, here it says above age 50, I mean 40 to 50, consider pancreatic adenocarcinoma. And the earlier you diagnose it, the better. Patients will present with that double duct sign, dilatation of the pancreatic and the bile duct, and they will be jaundiced because there is bile duct that is obstructed because of the pancreatic head mass. Patients will have abdominal pain and weight loss. The best test is a CT with contrast and endoscopic ultrasound to make a diagnosis, to do an FNA. Pancreatic cystic neoplasms, I just left it there. You don't need to know that for the time being. Pancreatic neuroendocrine tumors, these are also low yield for boards, but these are other questions, other type of pancreatic tumors, not just pancreatic adenocarcinoma, but there are other types of pancreatic cancers. VIPoma, where there is profuse secretory diarrhea, and which is called as a pancreatic cholera. So if you have a patient with very bad diarrhea, and if you see a pancreatic mass, think of VIPoma. Gastroma is what we saw, what we mentioned yesterday, patients with multiple duodenal ulcers. So if you see a patient with elevated gastrin, multiple duodenal ulcers and pancreatitis, think of gastroma. Insuloma, you will think of, hypoglycemic symptoms. Glucagonoma, you have this typical the migratory erythema on the skin, then there are somatostatinomas which may not have any typical symptoms to pick it up. Okay, so that is about pancreas. Now we are going into bile duct and gallstones. Why is there gallstone formation? The bile can be too thick. There could be nucleation of those microcrystals. When the bile is too thick, there is crystals that form. Those small crystals become big crystals, and those become stones. And when the gallbladder does not empty due to high progesterone state, due to any medication that inhibits gallbladder contractility, these are all the risk factors for cholelithiasis. Cholelithiasis is, as I mentioned before, stones are typically cholesterol stones, so you may not pick it up on CT. You need an ultrasound, except in cases of pigment stones or calcified stones because of hemolysis, where you might pick it up if there is calcification. What do you do to make a diagnosis of cholelithiasis? Abdominal ultrasound is 90% sensitive, and HIDA scan if you have a concern about cystic duct obstruction. And in a symptomatic patient, you do cholecystectomy. If sometimes patients can have gallstones, and majority of the patients who have gallstones don't have any symptoms. So in asymptomatic patients, if you don't have biliary colic, if you just have a gallstone identified on ultrasound done for another reason, you don't recommend a cholecystectomy. You only recommend cholecystectomy if the patients have complications associated with gallstones, such as cholecystitis or cholangitis, or in some cases, very big stone. Gallstones greater than 3 centimeters in size have been associated with malignancy, so you will take it out. But usually the small stones, if it is asymptomatic, you don't do anything. Acute cholecystitis, what do you do? What is happening in acute cholecystitis? I think I need to show the picture of the bile duct. I'll go back and come back here. So the first picture that I have, okay, you look here. Now this is the liver. This is the right and the left hepatic duct. They join together to become the common hepatic duct. And then there is a cystic duct. When the cystic duct joins the common hepatic duct, that is a common bile duct, and it then drains into the second part of the duodenum. So cholangitis is when there is a stone anywhere in the common bile duct. So there is backup of bile, and so that backup of bile leads to bacterial infection and jaundice and sepsis and fever. Acute cholecystitis is when a stone in the gallbladder is trying to get out of the gallbladder and it gets stuck in the cystic duct. So this is acute cholecystitis, when the obstruction is at the cystic duct. Cholangitis is when the obstruction is in the bile duct. Pancreatitis is when a small stone was obstructing the pancreatic duct. It may or may not be there. So you don't need to do an ERCP to drain it out unless the patient has cholangitis. But acute cholecystitis, so what you do, if the patient has acute cholecystitis, if the patient is a good surgical candidate, you take out the gallbladder. Otherwise, if the stone is sitting there and causing swelling of the gallbladder, it is going to perforate, right? But if the patient is a poor surgical candidate, then you place a tube, the cholecystostomy tube, either through the skin or endoscopically. Our interventional endoscopists now can go through the through the duodenum and make a puncture into the gallbladder internally without having to place an external tube. So you can drain the gallbladder either externally or internally, and you can prevent the gallbladder rupture leading to peritonitis. So for acute cholecystitis, you either do a cholecystectomy or do a drainage of the gallbladder so it doesn't perforate. For acute cholangitis, you go into the bile duct through ERCP and pull the stone out. For acute pancreatitis, you give fluids and do whatever else is needed as we discussed. Okay, so now let's go back to, where was it? Okay, I'm stuck here. Any questions in the meantime while I try to get back to the slide where I was? Okay, I think I am there. Okay. So cholecystostomy tubes, okay, oh my goodness. Okay, cholecystostomy tubes, you do that for patients who are very sick who cannot undergo cholecystectomy. Cholecystostomy can be percutaneous or through EUS guided. Laparoscopic cholecystectomy for patients who can tolerate surgery. And in pregnancy, if a pregnant female presents with acute cholecystitis, the best time to do the cholecystectomy is in the second trimester. So that might be a question. If you have a sick patient in the ICU who is continuing to have fever and you are not finding a source, look for a calculus cholecystitis. So in that case, it's not a stone that is causing the cystic duct obstruction, but the cystic duct is just not contracting well, and it is akinetic to the point that the contents, the gallbladder fluid is accumulating in the gallbladder and behaving like a stone that is causing cystic duct obstruction. In such patients, you will need to consider percutaneous cholecystostomy tube with IV antibiotics because these are very sick patients and they cannot undergo cholecystectomy. Gallbladder polyp, that might be a question. So if you have a patient, I'm not talking about stone, I'm talking about gallbladder polyp. So stones, how do you differentiate between stone and polyp on imaging? Stones will cast a shadow. So the radiologist can say this is a stone, but polyps will not cast a shadow. So polyps greater than 1 centimeter, such patients should undergo cholecystectomy. I actually talked to one of my staff today, this evening. I had ordered an ultrasound for that person, and the ultrasound is showing a 1 centimeter polyp. So I was asked what to do. I said, go for cholecystectomy because this polyp has the potential to become a cancer, and gallbladder adenocarcinoma has a poor prognosis. If you pick it up late, you will have to do a liver resection also. So get the gallbladder out. So you do cholecystectomy in asymptomatic patients. I remember I mentioned before, if you have a small stone in the gallbladder, you're not going to do cholecystectomy. But if you have a polyp greater than 1 centimeter in size, or if you have a gallstone greater than 3 centimeters in size, and there are other conditions, the calcified gallbladder or the porcelain gallbladder, these are all situations where you do cholecystectomy even in asymptomatic patients. Remember the indications for cholecystectomy in asymptomatic patients: gallbladder polyp greater than 1 centimeter, porcelain gallbladder, or gallstone, which is very big, greater than 3 centimeter. You probably won't see such stones here. I have not. I've seen such stones during my training back in India, but I have not seen a gallstone greater than 3 centimeters because those patients will be picked up and some complications would have happened. This is a porcelain gallbladder. There's a high risk for cancer. You can see the calcification around the gallbladder. So that is what these are the patients that need cholecystectomy. Now, this is a very useful slide, not just for your boards, but also for your day-to-day consult of GI service for ERCPs. So when you have a patient with stone in the bile duct, when do you ask for an ERCP? Yes, if you identify a stone in the bile duct, that needs to come out. So if the ultrasound shows that there is a stone in the bile duct and if the patient has abnormal LFTs, then the patient needs to have the stone removed. Or if you have a bilirubin greater than 4 and dilated bile duct. So in a patient with gallbladder that is intact, the bile duct should be greater than 6 millimeter. Or if the patient's gallbladder is removed, dilation should be greater than 8 millimeter. Or if the patient has ascending cholangitis. These are the 3 conditions where patients should go straight for ERCP. In other cases, where the patient just has some abnormal LFTs or has some mild bile duct dilatation with no stone that you are seeing, there is no real reason to subject the patient to ERCP because ERCP can cause pancreatitis, right? So you subject them to endoscopic ultrasound or MRCP or a laparoscopic cholecystectomy. And at the time of the cholecystectomy, we will ask the surgeon to do a intraoperative cholangiogram. So they can do a cholangiogram, shoot contrast into the bile duct. If they find a stone, they will let us know and we will go and take out the stone. So when do you refer patient for ERCP? If you identify a stone in the bile duct, or if the bilirubin is greater than 4 along with the dilated bile duct, or if there is ascending cholangitis. Acute cholangitis, I mentioned the Charcot's triad, which has fever, pain, and jaundice, the Raynaud's pentad with shock and altered mental status. Treatment is IV, starts antibiotics right away, and ERCP. Biliary neoplasms, you don't need to. Okay, now we are moving to what we call as PBC. PBC is primary biliary cholangitis. So, when you want to think about PBC and PSC, remember we mentioned about PSC yesterday, primary sclerosing cholangitis. That is what you see in patients with ulcerative colitis. PBC is what you see in the typical middle-aged female patients who come in with elevated alkaline phosphatase. So whenever you have a patient who has unexplained alkaline phosphatase elevation on LFTs, you have to think of a bile duct disease. And when you think about bile duct disease, we often think about the bile duct dilatation and the big ducts. But think about bile ducts and the biliary tree as a tree. The tree has a trunk, branches, and twigs and leaves, right? So in the same way, the bile duct that inside the liver, there is the twigs and the branches, but they join together, becoming big branches, and then which is the right and the left hepatic duct, and then it joins the cystic duct and becomes a common bile duct. That's a trunk. So a disease can involve either the twigs and branches or the small branches or the trunk. When it involves the trunk is when you start seeing cholangitis with a big stone obstructing the bile duct. If the disease involves the trunk and the big branches, that is what we call as primary sclerosing cholangitis. Again, these are things that you can identify on an imaging study. But PBC, primary biliary cholangitis, involves the leaves and the twigs, the small bile ducts that you cannot see on imaging studies. So these patients, the PBC diagnosis to make, you should have what we call as anti-mitochondrial antibody, or we call it as AMA, anti-mitochondrial antibody. So if you have a middle-aged female patient with elevated alkaline phosphatase, you send, and of course you will get an ultrasound to look for gallstones and to look for obstruction of the big bile duct. If you don't see a big bile duct obstruction, you obtain an anti-mitochondrial antibody. If the anti-mitochondrial antibody is elevated, the diagnosis of PBC is established. It's very specific. Elevated anti-mitochondrial antibody along with elevated alkaline phosphatase clinches the diagnosis of PBC. So PBC is important to pick up because if you treat those patients early with ursodeol, ursodeoxycholic acid, and some of these patients, you can prevent the progression of their ongoing liver disease to cirrhosis. But sometimes it is missed, and we see patients later on with cirrhosis. And some patients with PBC, even if you treat them with ursodeoxycholic acid, they will not improve. That's okay, but at least make a diagnosis of PBC and identify cirrhosis at an early stage that you can intervene or look out for complications of cirrhosis. So PBC, think of a disease involving the small branches and the leaves and the twigs, and it is not found on imaging study. It is based on a alkaline phosphatase elevation and positive anti-mitochondrial antibody. And if both are, if the patient has elevated anti-mitochondrial antibody and negative normal alkaline phosphatase, I might do a liver biopsy, to look for changes of PBC, because liver biopsy will show characteristic features, but you don't need to do liver biopsy if a patient has elevated anti-mitochondrial antibody and alkaline phosphatase levels. So what is how do you diagnose? I mentioned already, liver biopsy may sometimes be performed. Ursodeol is the treatment for PBC. And that is different from PSC. This is PSC that I mentioned yesterday. This you pick up mainly with imaging studies because it involves a bigger bile ducts that you can see on an ERCP or with an MRCP. There is an entity called small duct PSC, where PSC is involving the twigs and the leaves. That you need a biopsy, but I don't think you need to know that. The PBC is the disease of the twigs and the leaves, and PSC is a disease of the bigger bile ducts. And PSC is the one that you see in patients with UC. PSC and UC go together. If you have a patient, 75% of patients with PSC will have ulcerative colitis, but only 5% of the ulcerative colitis patients will have PSC. And you suspect PBC and PSC, primary sclerosing cholangitis, when a patient has elevated alkaline phosphatase. And for PSC, you do MRCP to make the diagnosis. And for PBC, you get an anti-mitochondrial antibody. I keep saying this again and again because it is confused all the time. And there will be questions on the boards on PBC, PSC for sure, PBC most likely. What is the natural history of PSC? Some patients, again, can go on to develop liver cancer and can cholangiocarcinoma and also can develop cirrhosis and complications of cirrhosis. PSC is a disease that you cannot really predict how patients are going to behave. When I was a GI fellow in 2008, 2009, there was an 18-year-old lady patient that I saw who had ulcerative colitis and PSC. Someone had gone to a room and told her, oh, you have a diagnosis of PSC and ulcerative colitis and you are not going to survive beyond 3 or 4 years. I remember she was in very bad, she was really shaken up. She was very young. And then eventually she decided to get her, she had ulcerative colitis. So she decided to get her colon removed. She underwent a colectomy. So she had she still has a, colostomy. And then her PSC did not progress. And now she still follows me in clinic. She got married. She has 3 or 4 kids. On the other hand, there are other patients with PSC that I have seen 6 months ago who are not alive now, who developed cholangiocarcinoma and died. Or there's another patient of mine with ulcerative colitis and PSC who required a liver transplant but was not getting a liver, and his ex-girlfriend donated him half of her liver and he is now doing well. So PSC can have very varied progression. We cannot predict how they behave, but PSC patients, most of them will have ulcerative colitis. I'm saying all these stories so you'll remember PSC, ulcerative colitis, PBC, middle-aged women with elevated alkaline phosphatase and positive AML. Treatment of PSC, ursodeoxycholic acid is not proven to be effective. Only sure treatment that will work is liver transplantation. Colectomy will help the ulcerative colitis, but will not do anything with the PSC. Okay, PBC and PSC, I put a table there for you to remember. Look just before boards. If you don't have time, look at this table. Now we are moving to liver to talk about other important liver diseases that you need to know. Any questions on pancreas, gallbladder, or bile duct that we have discussed so far? Okay, hearing none, I'm moving on to liver. When you see abnormal LFTs, try to look at it as whether it is an elevation of AST, ALT, or an elevation of alkaline phosphatase. If it's predominant AST, ALT elevation, you call it as hepatocellular pattern. If it's predominant alkaline phosphatase elevation, you call it as cholestatic. If you see just AST elevation or a much high AST elevation compared to ALT, think of extrahepatic source like muscle, rhabdomyolysis, and all such things. Alkaline phosphatase can be from other sources like the bone, intestine, placenta, and kidney. So if you have a patient with just the alkaline phosphatase elevation, without AST, ALT elevation, think of extrahepatic cause also. So how do you approach a patient when you have a patient with elevated alkaline phosphatase and all other liver tests, AST, ALT, bilirubin, everything is normal? Then you do a GGT, the gamma glutamyl-transferase. If GGT is elevated, then the source of alkaline phosphatase elevation is most likely coming from the liver. If the GGT is normal, you look for a bone lesion, or the patient might be pregnant, or intestinal alkaline phosphatase fraction. So, but you don't have to order a GGT if the patient's AST and ALT are elevated, because then that is coming from the liver. If it's only isolated alkaline phosphatase elevation, then you look at the GGT. And yesterday I had mentioned for your boards, you will see a question of a patient with mild AST ALT elevation who might have iron deficiency anemia and who might have diarrhea. When you get this question, you're thinking of infectious causes and this and that. but think of celiac disease. When you have mild AST elevation and diarrhea and iron deficiency anemia, think of celiac disease. Jaundice, I will not go into the details of jaundice because that's a topic in itself. And I put in some important things that you can review here. Let me see, what is it that you need to, okay, I'm skipping jaundice because I've explained it there as to what you need to read. So when you want to assess the severity of liver dysfunction, if you have a patient with cirrhosis that you see in the clinic, if they ask you, how bad is my liver? You are not, when am I going to, how long am I going to live? What is my, how bad is the liver? You don't look at the AST, ALT or the alkaline phosphatase. You look at two things. One is calculate their MEL score or calculate their child Pugh-Turk CPT score. And based on that, you put the patient as child A, B, or C. On MEL score will also give you the calculation of the predicted 3-month survival. But think of MEL score this way. MEL score, ideally it predicts the survival in a patient that you see in clinic. When a patient with cirrhosis comes in with renal failure due to some other cause, or if a patient with cirrhosis comes in for a hypercoagulable condition and that patient is on warfarin, their INR will be elevated, their MEL score will be elevated, and that may not be an accurate prediction of their 3-month survival. But in the baseline stage, MEL score is a good predictor of patient survival. Hepatitis A, I'm not discussing this because it's self-explanatory. Acute hepatitis B is important just because I want you to all to remember this window period of acute hepatitis B. So acute hepatitis B is when, say, you had a high risk exposure to a patient with, or body fluids of a patient with hepatitis B, and 3 months later you start becoming jaundiced. Sometime around the 4th month, if you check hepatitis B surface antigen, it may be undetectable because the surface antigen might be disappearing and the surface antibody may be coming up. The only test that might be positive is hepatitis B core antibody IgM. So if you can order only one test for patients with acute hepatitis B to diagnose acute hepatitis B, order hepatitis B core antibody IgM. If you can order 2 tests, order and hepatitis B surface antigen along with the core antibody IgM. And this is what we learned in medical school. This slide is still very useful. So this is what I meant to say. So if you had around the 12th or the 16th week after the infection, you see that the surface antigen came up. The patient is jaundiced, but the surface antigen titers levels are coming down. But look at the core antibody IgM. The core antibody IgM is still elevated. So if you just rely on surface antigen, you will miss the diagnosis of acute hepatitis B. So when you do the acute viral hepatitis panel, make sure that you are sending a core antibody IgM also. I think that is part of the panel, but they are not sending hepatitis C RNA, which I will come to later. So that is the window period of hepatitis B where the surface antigen is disappearing, but only the core antibody IgM is positive. Chronic hepatitis B is when you have acute hepatitis B that does not resolve. So if you or I get hepatitis B today, assuming that we are not vaccinated, 90% of the time we are going to clear the infection and we will have immunity. But if you or I were to get hepatitis B as a child, intrauterine from our mother who had hepatitis B or at the time of birth, 90% of the time you're going to develop into chronic hepatitis B. So hepatitis B developed that you contract as a child invariably go into chronicity. Hepatitis B that you contract as an adult, most of the times you have immunity. That is one thing to remember. The other thing to remember for boards with chronic hepatitis B is when to treat. Okay, it's confusing even for GI fellows and also for some GI attendings. What I would say for hepatitis B, for you to remember, I put in some slides here, but I'm not explaining that in detail. For you, for boards, treat if ALT is high. So if you have a patient with, I'm not talking about acute hepatitis B. Acute hepatitis B, majority of them will resolve. So you wait for 6 months to see whether the surface antigen is still present. And that's how you differentiate between acute and chronic hepatitis B. But if the surface antigen is present beyond 6 months, then you look at the ALT. If the ALT is high, if there is an option for start treatment, you choose the that you will treat the patient. They don't look at the viral load and decide whether to treat the patient or not. So for boards, you look at the ALT, and if you see that a patient with chronic hepatitis B being defined as surface antigen that is elevated beyond 6 months, or that is positive beyond 6 months, you treat the patient if the ALT is high. Why is, if you decide not to treat, meaning if the ALT is normal, you still have to do hepatocellular carcinoma surveillance because hepatitis B is a carcinogenic virus. So you do HCC surveillance in Asian or Black men over age 40 or women over 50 years. If they have cirrhosis, any patient with cirrhosis, you have to do liver cancer surveillance, or if they have a family history of HCC. Other things you can read later, but I only want to concentrate on boards for this lecture. So treat chronic hepatitis B if the ALT is high. Okay. Hepatitis B vaccination, I have mentioned some points there. When you have a neonate with hepatitis B that the neonate contracted from the mother, you have to give both vaccine and immunoglobulin, hepatitis B IG, HBIG. In the same way, individual with acute hepatitis B, there might be a question, you give vaccination and HBIG to sexual contacts of this individual and infants cared for by this individual. That might be a question for both. What are the agents that you treat hepatitis B with? It's adifovir and tenofovir. Adifovir is no longer being used. It's tenofovir what is being used these days, and entecavir. So the other medications are not used commonly. So entecavir and tenofovir are the typical hepatitis B treatment agents. There are some extrahepatic manifestations of hepatitis B, including mixed cryoglobulinemia and polyneuropathy. But those questions invariably will have hepatitis B, the diagnosis of hepatitis B listed there. Hepatitis C is important for both. And in hepatitis C, majority of the time, if you get hepatitis C as an adult, you are going to develop chronic hepatitis C. You are not going to clear the infection. So that's the difference between B and C. B, if you get it, majority of the time as an adult, you're going to clear it. But C, if you get it, majority of the time, you're going to develop chronic hepatitis C. So, but now C is curable. The treatment, the pills that are available to treat hepatitis C gets rid of the virus completely or cures the virus. But hepatitis B, you can never cure the virus. I mean, it's very difficult to cure the virus. It's like HIV. You give the medication, you keep the viral load under control, but the chance of cure is very, very low. So if you have to pick between B and C now, I would pick C any day because that can be cured. If you had asked me that question many years ago, I would have said I might pick B because I can keep the virus load under control, and there was no cure for C at that time point. So natural history of HCV infection, I'm not going to go there. Mixed cryoglobulinemia, a patient with hepatitis C and renal failure, think of that as a possibility. These are some of the skin lesions, and the PCT, the porphyria cutanea tarda. These are all some extra hepatic manifestations of hepatitis C. Treatment of hepatitis C, the guidelines are changing. I mean, there are newer medications that are coming up. The older medications, interferon and ribavirin, are no longer used. The newer medications with or without ribavirin have excellent cure rate with 95% cure rate. And so they may not ask you to remember the names of the hepatitis C treatment agents yet, but in a couple of years, that could be a very legitimate question for boards. And how is liver fibrosis determined? How do you diagnose cirrhosis or advanced fibrosis? If on imaging studies, on an abdominal ultrasound, if you see a nodular liver with a large spleen, you know that there is cirrhosis. There is another test called FibroScan, which measures the stiffness of the liver. The stiffer the liver, the higher the degree of stage of fibrosis, and more likely the higher fibrotic patients leading on, progressing on to cirrhosis. Simple tests that you can do in clinic, the AST to platelet ratio index, the APRI score, or the fibrosis for calculators, things that you can do on MedCalc. You just put in FIB4 calculator or APRI score and plug in the patient's AST, platelet, ALT, and age. You will get a calculation and they'll give you the normal values there. So if these scores are high, those are suggestive of advanced fibrosis or cirrhosis. And also there are blood tests, the FibroSure test, which measures certain matrix proteins that are synthesized, that are released in excess with fibrosis. So these are all indirect markers of advanced liver fibrosis, but liver biopsy is the most definitive test. I have mentioned the names of some of the hepatitis C treatment agents just for you to know it, but you don't need to remember it. Hepatitis C treat everyone. So if there is a question on hepatitis C, but if they say that the patient has terminal cancer with expected survival of less than 6 months or a year, then you don't treat that patient. But in all other patients, if the patient can undergo treatment, of course, you will not treat pregnant women. And hepatitis C treatment is not proven to be safe in pregnancy. But in all other conditions or in pediatric patient populations, there are only certain medications that are approved. But in all cases, you treat the hepatitis C. But in hepatitis B, remember I told you, if the ALT is high, you treat it regardless of the viral load. And if the viral load is very high, sometimes you may not treat the hepatitis B if the ALT is normal. But in hepatitis C, you're not paying attention to the AST ALT. You treat it because the cure rate is extremely high with an 8 to 12 week course of treatment. And hepatitis D happens only if you have hepatitis B. So giving vaccines for hepatitis B protects you from not just hepatitis B, but also from hepatitis D. And hepatitis D is difficult to treat. These hepatitis D virus does not go away with oral pills. The way to get rid of hepatitis B is to treat hepatitis B and get rid of it. I remember I told you hepatitis B is difficult to treat. So getting rid of hepatitis D is even more difficult. Having said that, I have 2 patients now with hepatitis D that I am giving interferon treatment, and they are doing reasonably well. My hope is that I will be able to get it cleared, but the interferon treatment is extremely involved and difficult. But the treatment of hepatitis D is actually with interferon, which will help you get rid of hepatitis B in some patients. And hepatitis B vaccine prevents hepatitis B and D because you need to have B to have hepatitis D. Hepatitis E, again, like hepatitis A, is usually fecal oral transmission. Think about, remember the high risk acute liver failure or fulminant hepatitis that might happen in pregnant women in the 3rd trimester. So hepatitis E is, if you have a question stem about pregnancy with acute hepatitis, think of hepatitis E, especially if there's a history of travel, etc. So this is a summary of the serology of all the tests that you would see in hepatitis A, B, C, D, and D. I have listed out the antibodies as to what you can check and what is the confirmatory test. The only thing that I did not mention is hepatitis C antibody is a screening test, but don't think that all patients with positive antibody has actual infection. You always have to do a confirmatory HCV RNA. And one thing in the acute viral hepatitis panel that we do at the hospital, we look at hepatitis C antibody and not the RNA. In some patients in the very acute phase of hepatitis C, you may not have had enough time for the antibody to develop. So HCV RNA might be the only test that is positive if they have acute hepatitis C. So you could see that sometimes when GI gets consulted, we ask you to send an HCV RNA test also if you're suspecting acute hepatitis C. Okay, chronic hepatitis. Okay, this is about autoimmune hepatitis. We mentioned about viral hepatitis now. Now we are mentioning about autoimmune causes of hepatitis. They can be the type 1 and the type 2. So for autoimmune hepatitis, the antibodies that you have to look for are the ANA, the anti-nuclear antibody, and ASMA, the anti-smooth muscle antibody. So ANA and ASMA, anti-smooth muscle antibody, and AMA for autoimmune hepatitis. And remember, I told you AMA, anti-mitochondrial antibody for PBC. That is again an autoimmune condition, but not affecting the hepatocyte, but affecting the bile, right? But the biliary cells. So If you see patients with elevated AST, ALT, and if you're not suspecting viral hepatitis, send ANA and ASMA, and also look for immunoglobulin G, because with any autoimmune condition, there is increased production of immunoglobulins. And if IgG elevation is also there, you're strongly suspecting it, you need a liver biopsy to confirm the diagnosis. There is a scoring system to make a diagnosis of autoimmune hepatitis. I put it out there here, but liver biopsy is a must to make a diagnosis of autoimmune hepatitis. How do you treat autoimmune hepatitis? Somewhat like how you treat a patient with ulcerative colitis as inpatient, right? You give the patient high-dose steroids, bring the inflammation under control, and then you put the patient on azathioprine or 6-mercaptopurine, any of those medications that will keep the disease under quiescence without having to keep the patient on long-term prednisone treatment. And you need to have a liver biopsy. There are some medications, the nitrofurantoin, especially, nitrofurantoin is a medication that is sometimes given to postmenopausal women for their recurrent UTIs. I've seen a couple of cases where nitrofurantoin has caused autoimmune hepatitis and the patients leading to cirrhosis, who still see me in clinic. They have cirrhosis from autoimmune hepatitis, but it was due to chronic nitrofurantoin use. And methyl dopa and minocycline, these are other medications that can cause drug-induced autoimmune hepatitis. Drug-induced liver injury is another thing that can be tested for both. Please remember, Tylenol, yes, Tylenol or acetaminophen causes acute liver injury and can cause acute liver failure requiring liver transplant, but Tylenol never causes chronic liver injury or cirrhosis. Tylenol causes acute liver failure, but does not cause cirrhosis. And the safest analgesic in patients with cirrhosis is Tylenol in therapeutic in recommended doses, not in high doses. But the medications that can cause cirrhosis are methotrexate, isoniazid. These are medications that can lead, long-term use can cause steroids, and anabolic steroids and OCPs can cause cholestasis. Drug-induced liver injury can manifest as hepatocellular, where there is AST, ALT elevation predominantly, or cholestatic pattern where there is alkaline phosphatase elevation, or a mixed pattern. I have given the Tylenol toxicity, some discussion on that. You suspect that if in patients with acute liver failure, especially the transaminases AST, ALT will be in the thousands. You will not suspect Tylenol toxicity in a patient with AST, ALT in the few hundreds. If they are Tylenol toxicity, if it is when it manifests, it causes acute liver it causes severe liver injury with increased AST, ALT levels, and it is a diagnosis that you have to keep in mind when you have a patient with acute liver failure. Drug-induced other hepatitis, you can read that. Hereditary liver disease, Wilson's disease, is a disease where there is increased accumulation of copper within the liver. The patients can present with any type of liver test abnormalities. And also this is another case where patients might present with acute liver failure, like the Tylenol toxicity patient. Serum ceruloplasmin can be low. The KF ring, Kaiser-Fleischer ring, and the urinary and the serum copper could be high. And on liver biopsy, you will see high levels of copper. And you have to sometimes do a liver transplant to save these patients, especially if they are coming in with acute liver failure. It's suspect this, and Wilson's disease can present as acute liver failure. Wilson's disease can present as cirrhosis. So if you see a patient with abnormal LFT, especially if the patient is less than 40 years, always exclude Wilson's disease because it can present in many, many ways. But Wilson's disease is extremely rare to be diagnosed for the first time in someone in his or her 60s or 70s. So it's usually a disease that is diagnosed when someone is younger than 40 years of age. What is the treatment of Wilson's? I don't think you will be asked that. You basically try to get rid of the excess copper and you put them on some maintenance therapy to prevent absorption of copper. Alpha-1 antitrypsin deficiency might be very important for pulmonary, not high yield for GI for boards. But the one thing to remember for alpha-1 antitrypsin deficiency is in pulmonary manifestations of emphysema, happens because of the deficiency of the enzyme. So replacing the enzyme helps. In liver, it's actually due to accumulation of the misfolded protein. So replacement of the enzyme does not help in liver disease. The only thing that helps in alpha and antitrypsin deficiency causing liver disease is a liver transplant. But if you do a liver transplant, you will start secreting appropriate amounts of alpha and antitrypsin, so the lung disease can be corrected. Liver disease is not due to a deficiency. Pulmonary manifestations are due to deficiency. So alpha and antitrypsin supplementation will help the pulmonary manifestation, but will not help the liver manifestations. Hemochromatosis is very important for boards and very important in real life, because you will see a patient with hemochromatosis in your practice. It's the most common form, it's the most common hereditary or genetically transmitted disease amongst Caucasians, particularly in patients of Italian and Irish ancestry. How do you diagnose it? If you see a patient with abnormal LFT, elevated AST, ALT, and you don't even, I mean, yes, there could be alcohol use, there could be viral hepatitis and all those things. But if you don't have any of those classic history, always check serum ferritin and transferrin saturation. Because if serum ferritin and transferrin saturation are both elevated, then that should prompt you to check for hemochromatosis gene mutation, which is called as HFE gene mutation. And there is a particular phenotype, C282Y homozygosity, or C282Y63D compound heterozygosity, that clinches the diagnosis. So when do you diagnose it? In any patient with abnormal LFT, in whom you are seeing elevated ferritin and transferrin saturation. For boards, you might see a patient with cirrhosis with the bronze diabetes because of the pigmentation of the skin and the pancreatic deposition of iron causing diabetes, and the cardiac failure because of cardiomyopathy, or infertility because of iron deposition in the reproductive organs, or arthritis because of joint involvement. So those might be the buzzwords for boards. But when you see patients, any patient with abnormal LFT and elevated ferritin and transferrin saturation, think of hemochromatosis. And patients with hemochromatosis have a very high incidence of liver cancer or HCC. Liver biopsy is not always required. You make the diagnosis with elevated ferritin and transferrin saturation, and you confirm it with the HFE gene testing. And what is the treatment? Getting rid of blood. So your patients come in and get around 300 to 400 cc's of blood taken out, and that blood is wasted. So because there is excess of iron in the blood, and you're trying to get rid of the excess iron in the blood, making the patient ferritin to go to around 50 to 100 nanograms per milliliter. So phlebotomy is the treatment of choice. And if you pick it up early, and if you subject the patient to phlebotomy, you can keep the disease under control. Patients will not develop any complication. So read about hemochromatosis in detail. Alcoholic hepatitis, you see these patients all the time on the hospital. So typically they will have AST much higher than ALT, but never above 500. If you see AST or ALT greater than 500, it is not due to alcoholic hepatitis alone. They could have coexisting other disease or Tylenol overdose on top of that. Give prednisolone. Prednisolone is the treatment if their Maddrey discriminant function is greater than 32. Maddrey score is greater than 32. And prednisolone may be stopped if there is no improvement of the bilirubin, or if there is no improvement of Lille score. These are also scores that you calculate online at day 7. So at day 7, or sometimes you can even calculate the score at day 5 and see if there is any improvement of the Lille score. If there is no improvement, you stop prednisolone. If there is improvement, you continue prednisolone for beyond to up to 28 days or 4 weeks, and after that you stop it. So I said you will never see AST above greater than 500. When you see AST above ALT above 1000, what are the possibilities? Ischemic hepatitis, when there is cardiogenic shock, or ICU patient with septic shock who comes in with hypoperfusion. Tylenol toxicity. If you have viral hepatitis, any acute viral hepatitis, hepatitis A, B, C, D, or E, can give you AST, ALT in the thousands. If you have autoimmune hepatitis, can give you AST, ALT in the thousands. Sometimes in the acute phase of biliary obstruction, you might see AST, ALT much high. But most of the times when you see the patients in the ED, the acute phase has passed and you will see the alkaline phosphatase elevation. But in the acute phase, you might see AST/ALT greater than 1000. So these are the conditions to suspect when you see a patient with AST/ALT greater than 1000, and never make a diagnosis of alcoholic hepatitis if the AST/ALT is greater than 500 in that patient, because then you are missing something and concentrating on alcoholic hepatitis in a patient who is not drinking in excess amounts to cause alcoholic hepatitis. And then there is a non-alcoholic fatty liver disease, which again behaves the same way like alcoholic liver disease, except that the patient is not consuming excess of alcohol. Excess of alcohol being defined as greater than 3 drinks per day in men and greater than 2 drinks per day in women. So if a patient drinks more than 3 drinks per day, then you consider that diagnosis as due to alcoholic liver disease. If it's less than 3 drinks, but if they have fatty liver, then you call it as non-alcoholic fatty liver disease. What is the treatment? Treatment is weight loss. Vitamin E can be given in non-diabetics if they have steatohepatitis. Pioglitazone can be tried. GLP-1 agonists, I will update this slide and send that to you, can be tried in diabetics. Obeticholic acid is not been proven to be effective. And control of diabetes and dyslipidemia is important. So give statins to these patients because they are more likely going to die of their cardiovascular disease and not due to their fatty liver complications. So never withhold statins in patients with fatty liver because they need it more than anyone else because they have a high risk for coexistent cardiovascular disease or cerebrovascular disease. But weight loss is the best and the most effective treatment for patients with fatty liver disease. Acute liver failure, I told you that Tylenol can cause acute liver failure. When do you make that diagnosis? When there is a patient who has no pre-existing cirrhosis or liver disease, who comes in with acute confusion and acute coagulopathy. Acute confusion defined as encephalopathy or coagulopathy defined as INR greater than 1.5. If such a patient presents, then you have to call the transplant center to see whether the patient is a transplant candidate, and you start the patient on N-acetylcysteine. N-acetylcysteine is indicated in Tylenol as well as in non-Tylenol related acute liver failure. So acute liver failure is unexplained encephalopathy and coagulopathy in a patient with no pre-existing liver disease. Hepatocellular carcinoma, liver cancer, is common in patients with cirrhosis. It's also common in patients with hepatitis B who do not have cirrhosis. So check for hepatocellular carcinoma in all patients with cirrhosis and in patients with hepatitis B. Generally, you screen for hepatocellular carcinoma with ultrasound and alpha fetoprotein. Whenever a patient with cirrhosis comes in with decompensation of no obvious etiology, think of hepatocellular carcinoma. What is the treatment of hepatocellular carcinoma? Transplantation. So, if you have cancer of the liver, taking out the liver and putting in a new liver is a treatment as long as the lesion is not greater than 5 centimeters in size, or if there are not more than 3 lesions and all the lesions being less than 3 centimeters in size. In patients who are not transplant candidates, you can consider chemo and radiofrequency ablation. If the patient does not have advanced cirrhosis, meaning if the patient has child A or child B cirrhosis with no significant portal hypertension, resection of the tumor is okay. But if the patient has advanced liver disease, patients need transplant. Cirrhosis, esophageal variceal bleeding, these are pictures of esophageal varices. And when do you screen for varices? You screen for varices in all patients with cirrhosis every 3 years. And if you find small varices, you don't put them on beta blockers. But if you see large varices, you put them on beta blockers. If you see small varices in decompensated cirrhotics, you put them on beta blockers. But in compensated cirrhotics, you do not put them on beta blockers. I will share these slides, but make sure that you screen all patients with cirrhosis with the EGD to look for varices. And when you have a patient with acute variceal bleeding, you give them octreotide and IV antibiotics. You should not over transfuse. IV antibiotics prevents further bleeding and also improves survival in patients with variceal bleeding. Hepatic encephalopathy, you make the diagnosis based on clinical suspicion, based on number connection test. Serum ammonia is never helpful. If you have a patient with an unexplained confusion and if the ammonia is elevated, that might be a tip off to look for cirrhosis. But otherwise, hepatic encephalopathy can be diagnosed in patients with normal ammonia levels, hepatic encephalopathy. And in some patients with hepatic encephalopathy, the ammonia level can be very high and the patient can be high and the patient may not have hepatic encephalopathy. So ammonia is not, if you see ammonia as a test choice on boards, don't fall for that, because that is not the right answer. How do you treat encephalopathy? These are discussed in our lectures before. You identify the precipitating factors and you treat with lactulose. And if there is no response, you add rifaximin. Okay. Hepatorenal syndrome is renal failure happening in patients with acute with cirrhosis. There is type 1 and type 2. That was older terminology. Now newer terminology has come up. HRS, CKD and AKD, NAKD, non-acute kidney disease and chronic kidney disease. I don't think they will ask that for your boards yet. So I still decided to keep type 1 and type 2 as a classification, but it will change in, it has already changed in the GI boards, but it will not, it has not changed for internal medicine boards. But I will put that slide, I will add that slide also for your information in case, you know, that comes up. You need to know what is type 1 HRS and what is type 2 and what is the new terminology for that. Ascites, when patients with cirrhosis have ascites, you always get albumin and protein of this ascites fluid. If the, and calculate the SAG, serum ascites albumin gradient. If that is greater than 1.1, it is portal hypertension. If it is less than 1.1, then you're thinking of a peritoneal cause, not a portal hypertensive cause like peritoneal carcinomatosis, TB, and things like that. And in a patient with high SAG, meaning greater than 1.1 serum ascites albumin gradient, and if they have a high protein content of the ascitic fluid, you're thinking of cardiac causes, constrictive pericarditis, heart failure. But if the total protein of the ascitic fluid is less than 2.5, you are thinking of liver related causes. Always when you have a patient with ascites and when the patient gets hospitalized with any complaints, even if they have no symptoms of fever or abdominal pain, you should do a diagnostic paracentesis. And if the peritoneal fluid has more than 250 neutrophils, you should start them on antibiotics. So consider paracentesis in all patients with cirrhosis and ascites who gets hospitalized for a liver-related or an unexplained diagnosis. Spontaneous bacterial peritonitis, if you make the diagnosis, you have to give them antibiotics. You also have to give them IV albumin on day 1 and day 3. So placing them on prophylactic antibiotics do not do the complete treatment for the patients because they need to get IV albumin. And then once they are discharged from the hospital, they need to be placed on prophylaxis. For bacterial peritonitis, so they need to be placed on lifelong antibiotics to prevent them from getting another episode of bacterial peritonitis. So doing a paracentesis is very important. There are other conditions in patients with ascites that you give primary prophylaxis, like to prevent an episode of SBP, the first episode of SBP. That you do if their total, if the ascitic fluid total protein content is less than 1.5, and if they have concomitant renal failure or liver failure, especially if their child putrid score is greater than 9. And in patient with patients, as I already mentioned, patients with cirrhosis who come in with bleeding, variceal bleeding or non-variceal bleeding, you give them short-term antibiotics, but not long-term antibiotics. And what do you give for prophylactic antibiotics? You give norfloxacin or Bactrim double strength 1 tablet a day. Norfloxacin or Bactrim DS is the treatment of choice. Treatment of ascites, you know that you restrict sodium and water, and water restriction only if the serum sodium, if there is hyponatremia, otherwise there is no role for restricting water. And you give spironolactone and furosemide at a 100 to 40 milligram dose ratio, and increase the dose every 3 days to titrate for the weight loss that the patient is experiencing. So ascitic fluid analysis, I have put in certain things that you need to know. These are things that you have to review just before boards. And treatment summary, I have listed it there. Liver transplantation, what are the indications? In patients with MEL score, if you have acute liver failure, or if you have a patient with cirrhosis and a MEL greater than 15, or a patients with early hepatocellular carcinoma where they meet the Milan criteria. These are the indications for liver transplantation. And Budd-Chiari syndrome is a syndrome where you see obstruction to the hepatic vein, patients present with right upper quadrant pain, ascites and jaundice. So always do an abdominal ultrasound Doppler whenever you have a patient with abdominal pain and ascites or jaundice, or in a patient in whom you are suspecting cirrhosis. Always do a right abdominal ultrasound with Doppler to look for obstruction of the hepatic vein. There are some liver disease unique to pregnancy that I have written here that you can read if you have the time, but I don't think hyperemesis gravidarum can be a question for boards in the first trimester. They might present with abnormal LFTs. So that's why I think of hyperemesis gravidarum as a cause of abnormal LFTs in the first trimester. Liver disease during pregnancy, you may read this at your convenience if you want to know more about hyperemesis gravidarum, because that could be a question. Adenoma can be a question for boards. So you might be given a scenario where a patient with a liver lesion, a patient is taking oral contraceptive pills, and the imaging studies are characteristic for adenoma. What do? You stop the oral contraceptive pills and see if the adenomas resolve. If the adenomas do not regress, and if the adenomas are greater than 5 centimeter, or if there are signs of hemorrhage, or if they have a particular mutation on biopsy, you have to resect it because there is a risk for malignant transformation. There is a risk for hemorrhage, especially if the size is greater than 5 centimeters. But if they are on birth control pills, the first thing to do is to stop the birth control pills. I have included some slides on nutrition that you can review if you have time. I'm not going to discuss this because there is no concept to discuss here. Manganese toxicity can be seen in long-term TPN use. Patients may present with Parkinson's symptoms and cholestasis. So if you have a question on a patient on long-term TPN with Parkinson's symptoms, think of manganese toxicity. And this is just for you to, I included these slides for you to review as you are doing the GI board review. As I said, for GI board review, if you do these slides and if you do the mix-up questions, you will do very, very well. And that's the reason why I put in all these things here. And you don't need to read any other textbook for GI board review. So I'm not discussing this in detail. This is only for your review later. And what is the thing that I would say to everyone before boards? If you don't have time, most of the times you will think that, oh, I have time to review everything. And you will realize the day before boards or the week before boards, you will be on the most busy rotation, or you will be working as a hospitalist with no time whatsoever to prepare for boards. If you don't have time, don't worry. Read statistics, because you will not remember it if you read it many days before. Just read statistics the day before boards and go for it. You will do well if you've been doing a good job as a resident. So that is it from GI. I will share these slides with the chief resident after I make some edits. And then if you have any questions on any of these, you can email me or you can ask me. But otherwise, good luck with your boards.
Thank you so much, Dr. John. Very informative.
Thank you. Thank you. Okay, I am leaving now. And I will share the slides with you. If I forget to share, just get in touch with me. I will send it to you. Okay.
Sounds good. Thank you.
Thank you. Have a good night.
Bye.